The screen sharing. So thank you everyone for coming to the UW-ISyE Colloquium. We're very lucky to have Carri Chan from Columbia Business School here. Carri does a lot of super interesting work in medical decision making and optimization and machine learning. And she's also done some really cool stuff with COVID recently. If you want to check that out. But without further ado, I'm not going to cut out into more of her time. I'll let her get started with her talk.
Great. Thank you so much for having me here. It's, we're slowly moving to a world where eventually we'll be doing in-person stuff, but not quite there fully yet. So I guess the silver lining is that we're able to do this much more seamlessly day to day. So I'm going to talk about some work that I've been doing with my colleague Jing Dong and our PhD student Yue Hu. We also have done some collaborations with a number of clinicians and people at some of the hospital systems in New York City. So I want to thank them because without them, this certainly would not have been possible. So today what I'm going to talk about is surge planning in emergency departments. And, I guess now it's not as hard to motivate why we need to have plans for surges at hospitals, but nonetheless, what I want to do is talk about how using predictive analytics has been growing in the space and how that can be used to guide some of these types of decisions. And I think within healthcare, the use of predictive analytics or the promise of predictive analytics is really exciting. I know many people here in the audience themselves are working in the healthcare space. And so many people certainly on the provider side are excited about the promise. And yet, in my opinion, there seems to be a gap in the sense that often it's let's build these predictions because it's going to help us make decisions. But then there's not that follow through on actually how do you make the decisions based on the prediction. And so this work really tries to operationalize some of these decisions based on those predictions we're making. So the motivation is that in emergency departments, there are often long waiting times. Just by some survey results, it doesn't even matter what type of hospital it is. Across the board, emergency departments feel that they're at or even over capacity in many situations. And certainly the last 2 years have pushed that even further out. So what we're going to be focusing on is looking at the nursing aspect of emergency care, in large part because the nurses are the ones who are providing the main management of the patients and a lot of the care. And they're also often the bottleneck resource. That said, I think the approach that I'm going to be discussing today can actually be applied to other resources, including physicians in the emergency department. So what is our primary motivation? So as I said earlier, the need to have surge plans is come, front and center to now the general public. But most hospitals prior to the pandemic had surge plans because, stochastic fluctuations, non-global pandemics, but, epidemics, local epidemics, mass casualty events, large car accidents could always increase demand over the supply of nurses around. So most hospitals have surge policies. What's involved in these policies is quite varied. So it can start with just, prioritizing discharges from the hospital so that you can move people into the hospital once those beds become freed. It can be, reducing elective services. And one common thing is also surging up capacity, increasing staffing. This can be done either by asking people to stay overtime or it can be by calling in additional staff from, just mute that, additional staff from agencies that can kind of be flexible in that way. And so we're going to be focusing on that aspect of that surge decision. And in particular, making these surge decisions, most hospitals have a number of criteria, and essentially it's, once the number of patients, the census exceeds some threshold, surge protocols are enacted. And it might be a phased approach, so there could be multiple thresholds that enact different parts of the policy, but it's really kind of a static state of the world. Once you get to this bad state, let's start surging. So we wanted to think about the fact that as data is becoming more sophisticated, the availability of data is becoming more sophisticated. Can we actually use real-time information about what's happening in the emergency department to have a better sense of what the demand is going to be in the coming shifts? And so if we need to surge, can we actually do a better job of matching the supply to demand? So this work is really twofold, trying to understand what's that value of that real-time information. But if we have it, and it does have some value in increasing predictive power, how do we actually incorporate that into our staffing decisions? So that's what I'm going to be focusing on today. I should also note, feel free at any time to unmute and interrupt me if there are any questions. Lost my mouse. There we go. All right, so thinking through how staffing is done, this is roughly how most hospitals do it. And you can think of this surge staffing decision is typically done in 2 phases. So the first phase we refer to as base staffing. So you can think of this as determining how many full-time employees, how many FTEs you are going to staff in each shift. And these are done weeks or months in advance at the hospital that we're working with. It's done 4 weeks in advance. This is essentially just like what is kind of our average demand that we expect to come. Because it's the number of FTEs, we're paying at a base level rate, essentially their salary rate. The challenge here is that 4 weeks in advance, or more than 4 weeks in advance, you don't know exactly what the state of the world is going to be in the shift that you're making that decision. There's a lot of uncertainty there. And as an example, where could that uncertainty come from? Well, you may know weeks in advance that January is in the middle of the flu season, but you don't know if it's going to be a good or a bad flu season, right? So demand is going to increase, but is it going to increase by a lot, or is it going to increase by a little? And so weeks in advance, you may not know that, but as you get closer, you start to see flu going up, you get a little bit more information. And so hopefully you can get a better sense of what the true demand is going to be. So that's where the surge staffing comes into place. It's hours in advance, you start to see that demand is increasing. You may not have enough staff to meet that demand. And so you can ask people to work overtime, or you bring in agency nurses to fill that gap. To do that, you have to pay at a higher rate. So typically that's 1.5, the base rate, but it can vary depending on the hospital and who you're actually bringing in. The potential benefit of this is you have much more information, right? So the costs, if you will, of getting it wrong, of having too much versus too few staff are much lower. And so there's a tension here, right? Should I make the decision? How much do I need to do weeks in advance? So I have a lot of uncertainty, but it's much less costly to staff then. And how much should I postpone until I have a lot more information available? Right. So I guess to just kind of calibrate us throughout this talk, we're going to be looking at trying to predict demand at the shift level. And this is very purposeful, rather than trying to predict at the hourly level, which many people in the emergency medicine literature have actually tried to do. And why is this? Because we are trying to guide and align this prediction with the actual operational decision we're making, which is staffing decisions, which is done at the shift level. So we want to know how many people are going to arrive within the shift. So here's just some data over from the Columbia University Medical Center, so from their adult emergency department. Over the course of about a year and a half, we have about 160,000 arrivals. And you can see that there's quite a big bit of difference, not surprisingly, between what happens during the day and what happens at the night. So during the day, you have much higher demand. This is not new. Everybody knew this is the case. But you also have actually quite a bit more dispersion in the arrival counts. So just trying to kind of build out that prediction, and I'm not going to go into all of the details on the prediction model. I'm more than happy to talk about it offline. It's more of a means to an end for us from a prediction standpoint. So for the base stage, weeks in advance, what type of information is available? You know, if it's a night or a day shift, you know what day of the week it is. We also incorporate kind of minimally major holidays as well. And so essentially here we're looking at average arrival counts. And, you know, we did various sophisticated models, but, you know, that average actually works quite well across these different time points. And you do see seasonality effects by day of week and time of day, not surprisingly. At the surge stage, we now have a lot more information. So there's been work that is done that has used information, other information to try to improve those predictions, including weather information. Something that we did was to not only include, you know, count information, but more information about what are the types of patients that have already arrived at the emergency room, right? So why would this potentially be valuable? Well, you can imagine that there are certain chronic illnesses that, you know, if external factors exacerbate those chronic illnesses, it might affect, you know, everybody with that chronic illness. And so you'll see an increase, and that could be useful for predictions. So as an example, if there are, you know, political events that are occurring that could exacerbate depression symptoms, then people who have who suffer from depression, you'll see an increase in overall demand for that comorbidity. And so we took that information as well to try to improve our predictions. So we find that, you know, having this real-time information, you know, not surprisingly, it improves the quality of the prediction, right? It improves it moderately. So actually the historical data, those, you know, day versus night and day of week effect actually capture a substantial amount of the variation. And you can get a little bit more improvement with this additional real-time information. So we looked at it in a couple of different measures, and I'm showing data from two different hospital systems. So this is Columbia's hospital system, and this is the Hackensack Hospital emergency room in New Jersey. And we're actually in the process of trying to get a pilot study up and running there in the next couple of weeks. So one thing to note is that with the Hackensack data, we actually had data from COVID. And so you can see that by going from the base stage prediction to the surge stage prediction, depending if you're using MSE or MAPE as your measure of fit, when you have information of whether or not you're in the middle of COVID, and that real-time information dramatically improves the performance. But you can see that there are improvements, but it's relatively moderate. We'll see that even with this moderate amount of improvement for the staffing decisions and the cost savings that we can get with this moderate amount, it ends up being fairly substantial. So you don't need to have a perfectly accurate prediction model to actually get these gains, which is good because we're never going to be able to predict the future perfectly. I wish, right? So maybe I'll just pause for a moment there before I kind of dig into the model of how do we do staffing and see if there's any questions so far about the prediction aspect. Okay.
One quick question for me. How many, like, so the error, like the MAPE of like, 10%, how many like arrivals is that? Is that that's what this is, right? Arrivals.
Yeah, so I think it corresponds to and
I guess square root of 220 would be kind of the same, right?
Yeah, so it's like what, like 10 or so
okay, yeah.
Patients. So I mean, it's not negligible, but if you're thinking about staffing and you have nurse to patient ratios in the ED that range from 1 to, like, let's say 4 to 6 optimistically, then it corresponds to maybe like two nurses or so, although we account for some of that variation in it, so it's not actually which is why it's actually fairly robust even to these types of errors, because our staffing decision is looking at metrics associated with access, but also cost, and accounting for the variability in the actual arrival counts decision.
Thank you.
Sure. Any other questions? All right. All right. So here's the big question that we wanted to answer, is that now we have these predictions at this 2 time scales. How do we actually make our staffing decisions on this? And so to do it, we build a queuing model that incorporates the uncertainty in the demand and then the partial resolution or full resolution of that uncertainty at that surge stage. And so how do you make your decisions appropriately? So let me just start by walking through what is the model that we are trying to analyze. So here we have
if that's on our end, I apologize. Please mute yourself unless you're asking a question, out of respect for our speaker. Thank you very much. Sorry about that, Carrie.
No, don't worry about it. I feel like at this point in our lives, we're all used to it. Unfortunately, there's also times where I speak for probably a minute or two, only to be told that nobody heard what I said because I forgot to unmute. So anyway, so here we have our queuing system. Just for simplicity for this talk, I'm going to normalize the service rate to 1, but if you're interested in the paper, it has a general arrival rate. We're going to try to determine how many servers we have here. And so you can think of the servers as like how many nurses, how many patients can actually be served simultaneously. So if you add 1 nurse, that could course with a nurse to patient ratio of 1 to 4, that would be adding 4 servers. Patients arrive according to a Poisson process, and they have exponential patience. So if they have to wait too long, they'll abandon the queue. Now, so the only difference in this model from the traditional MMN plus NQ is this arrival rate, capital lambda. And so here, this is where we're capturing the uncertainty in the arrival rate. So remembering back, I said, you may know that January is in the middle of the flu season, but you don't know if it's going to be a good or a bad flu season. So you could imagine that the lowercase lambda is that average arrival rate, and this random term R is going to increase if it's a bad flu season and decrease if it is a good flu season. So we have the same mean arrival rate, but we have this uncertainty that's captured by the random variable R that has 0 mean and is a finite expectation. Okay.
So I guess one quick question,
Please.
or maybe you're about to describe this in a second. So what's the time frame that we're assuming that R realizes for? Like, how often is R kind of resampled in this to capture the, go ahead, sorry.
You are right on point. So right now for this particular model, I'm going to be looking at it as basically I'm going to try to understand from a steady state standpoint. So there's one point you get a realized R, and I want to optimize my system over the potential distribution of that R, but you get a, that one time. In practice, obviously what's happening is every shift, this is changing, right? And so when we get into that, the numerics, I'll talk a little bit about some of the challenges that arise there, especially because we're optimizing over a shift. And with lengths of stay in the emergency department on order of 1 to 3 hours, you're not necessarily going to reach steady state in that 12-hour shift or 8-hour shift, depending on the hospital. And so we have to try to basically engineer our way through that.
Another question. So it does sound like you're trying to predict arrivals, and it's just over the shift. So is there any consideration for wait time, or is that sort of factored into just the arrival rate?
So when we are making the staffing decisions, and when I kind of talk about the optimization problem, the waiting time is critical. Right now, all I'm trying to do is predict counts and think about how do I staff based on that prediction of counts to manage the waiting time. One could imagine that because the profile of arrivals of patients may be heterogeneous, you could try to predict arrival counts and also severity of those patients, and their average service time in the emergency department. We are not at that point yet. There would be improvements, certainly with that additional information, but I don't think that necessarily the insight of what you would do would change that much. Any other questions? All right, so let's think about what information, I guess maybe this goes back to Jonathan's question, what information is available when you're trying to make your decisions? So the assumption that we're going to make is at the base stage, we know this average arrival rate lambda, and this is through that base stage prediction we're going to do, and it actually fits pretty well. We also know what the distribution is of R. So we know what type of variability we're going to have. We just don't know what the actual realization is. Oops. That should say realization of R. Maybe let me change it real time. So at the surge stage, we're going to assume, at least for this theoretical part right now, that we have the perfect realization of R. So we actually know at the surge level, what is the actual value of R. Now, this does not tell us exactly how many people are going to arrive, right? Because once you have the actual arrival rate, the number of arrivals is a Poisson process with that arrival rate. So we only know what the realization is of the arrival rate, not of the arrival counts. We can also relax this assumption and assume that we have kind of noisy predictions of that arrival count. And roughly the insights follow through, presuming that our prediction error is sufficiently small, not surprisingly. All right, so what is the staffing decision we want to make? So we have a number of primitives, the costs associated with staffing, and based on our earlier assumptions, the surge staffing cost is larger than the base staffing cost. Here is the way that we take waiting time into consideration. So one is that we have a holding cost. For each unit of time that a patient is waiting to be seen in the emergency department, there's a cost H associated with it. If they wait so long that they abandon, there's an abandonment cost associated with that as well. We make what we perceive as a fairly innocuous assumption that essentially says the quality metrics, these costs associated with waiting and abandonment, are sufficiently large that you actually want to staff nurses to the emergency department. If this is violated, then it becomes an optimal solution to have 0 nurses, which then means you close the emergency department. I suppose that happens in some places, but not very interesting regime for us to be looking at. And so what is the optimization problem that we are trying to solve? So we have this 2-stage approach. So first is, how many base nurses should we staff? So that's N1 at 4 weeks in advance. How many should we staff? And what decision that we're optimizing this over is over this random arrival rate lambda, which we don't know. At the second stage, we actually get the realization of that arrival rate. And so we are minimizing the costs of nursing plus this quality measure that depends on the queue length, and then these queuing, the linear holding costs and abandonment costs. All right. So you can see that essentially there's 3 different components: the staffing costs at the base stage, staffing costs at the surge stage, and then these quality metric costs. All right, so what's going to end up being critical here is that we have, as I alluded to, multiple different sources of randomness. So we refer to them in 2 ways. First is the demand uncertainty. We don't know what the arrival rate is going to be ahead of time. Is it going to be a good flu season? Is it going to be a bad flu season? All right, and that's the uncertainty that we're really faced with at that base stage. At the surge stage, there's still uncertainty. We now know what the actual arrival rate is going to be, but even with that arrival rate, there's system stochasticity due to the queuing process. So the arrival process is a Poisson process with that known arrival rate at the surge stage. So there's stochasticity there. There's also stochasticity in the service times, which and the abandonments, which are also Markovian. And so we are going to be looking at these 2 different measures of uncertainty. All right. Any questions on the model? What's happening here?
Carrie, really bad. This is Gabriel. Can you hear me okay?
Oh, yep, there you are. It's like coming through a tunnel.
Sorry, I'll put the video on. This is gonna be a bad. So sorry. So in the queuing, right? So you have Markovian dynamics, but then here, I'm assuming later on you want to incorporate, right, the prediction. So you're looking information into the future, right? In some sense, in this 2-stage thing. Is that sort of the way I'm interpreting that?
So the way that the prediction comes into play is that we are actually predicting what that arrival rate is going to be for the shift. And I'm actually assuming I have perfect right now, just for simplicity, that I have perfect prediction. So the way that the prediction comes into play is to say at the surge stage, so I'm actually making a decision on how much to staff before the shift has occurred. But I'm saying that at the time that the shift is about to start, I know what is the real what is going to be the realized arrival rate. Good. All right. So there's a vast literature that's related to this type of stuff, and mostly on the modeling side that I'm focusing on today. There's also a lot of work on the empirical side of how to do staffing appropriately, including those who are in the audience today. There's been a lot of work in the emergency department work trying to do demand forecastings. As I said earlier, primarily focused on hourly counts rather on the shift level. But from a modeling standpoint, there has been work that is trying to manage queues that have this parameter uncertainty when you have a random arrival rate. And so the most relevant papers I've highlighted in blue, and probably the most closely related is this work by Kosaga and actually Amy Ward and others, where they also have random arrival rates, but instead of making staffing decisions, they're making decisions of like who to admit and who not to admit. As far as we know, we're the first that kind of looks at the random arrival rate model, but what happens once if you have 2 periods of making a decision, and that second opportunity when you have much less uncertainty. Now, for those of you who don't work in the queuing space or in healthcare, this may also ring bells related to the supply chain literature with dual sourcing. So if you think about what we're trying to do here, you have 2 resource allocation decisions. Far in advance, it's cheaper, but more uncertainty. Then at the beginning of the shift, it's more expensive to add resources, but you have much less uncertainty. If you think about dual sourcing, where you have a near versus far supplier, if you have a far supplier, your lead times are longer, so you have more uncertainty about what demand is going to be. So when you're making those procurement decisions, you have to account for that higher uncertainty. Or you can pay for the near supplier that's much more costly, but has a shorter lead time. The distinction here, though, is that we have these queuing dynamics that arise that don't necessarily arise in that supply chain setting. All right, so what's really critical here is the fact that we have this arrival rate uncertainty. So let me just describe exactly how we're going to model the uncertainty in the arrival rate. So I mentioned we had the mean arrival rate lambda, and then we have our random component that we had that random variable r. So how do we model this? We're going to model it as a component lambda to the alpha times x, where x is a random 0 mean random variable. So this may look like a kind of a strange relationship if you haven't seen it before. So one is that this is a model of random arrival rates that has been used in those prior studies. What's going to be helpful here is that parameter alpha is going to turn out to be a really critical parameter. And so the way that you can think about it is depending on the size of your system. So how large is your lambda? And we're actually going to take an asymptotic approach where lambda goes to infinity. How does the random arrival rate scale with the amount of demand that you have? Is it scaling, if alpha is equal to 1, it's scaling actually quite rapidly, or is it's scaling at a less than linear rate? And so we'll see that that's going to end up being a really important component. What you can see here is that, by the construction of this arrival rate model, going back to that discussion of the types of uncertainty and randomness that we have, by construction, our demand uncertainty is on the order of lambda to the alpha, right? So we have this is our entire random component. And so it's scaling with our arrival rate depending on this alpha parameter. On the other hand, the system stochasticity classic results in the queuing literature tell us that, for these MMN variants of queues, that the stochasticity in that queue process is on the order of square root lambda, meaning your stochastic fluctuations in your queue length being above or below. So if you have a queue or if you have idleness, it's on the order of square root lambda. And so it's going to turn out this alpha, as I mentioned, is a critical parameter, but more importantly, how does alpha relate to this 1/2? So do you have more demand uncertainty relative to system stochasticity or vice versa? And that's going to dictate largely what you should do. All right, so our first question before we figure out how to do surge staffing is, should we do surge staffing in the first place? Like, is it actually beneficial to bring in additional staff? So what we wanted to do was do a comparison of the optimal 2-stage staffing cost. So I can, if I could solve this optimization problem exactly, how does this compare to the optimal single-stage staffing cost? So if I only had one opportunity to staff weeks in advance versus having these 2 opportunities. Now, right now, I have not said at all how I'm making these decisions. These are kind of like theoretical, what's the best I could possibly do? And so it turns out that we can characterize, even not knowing exactly what the optimal staffing decision is in these 2 settings, is that we can break out into 3 or kind of 2-ish regimes. So the first regime is when you have what we refer to as moderate uncertainty. So this is uncertainty in the demand rate. And so this is saying alpha is less than 1/2, meaning the amount of uncertainty in the arrival rate is less than the amount of fluctuations we see due to the natural queuing process in a Markovian queue, which is square root. And in that case, the gap between the optimal single stage versus optimal 2-stage scales as little o square root lambda. So what this means is essentially, as your system size grows, as your load on the system grows larger, the differences become negligible. You can't actually see any benefits to staffing at this second stage. In which case, if that's the scenario, like, don't bother trying to come up with a prediction model of your arrival counts. Don't bother trying to set up this surge staffing because you're not going to actually get cost savings. If the system stochasticity and the demand uncertainty are exactly equal, you get savings that scale with square root lambda. So you get some savings, but it's growing moderately fast. In the case where there's a lot of demand uncertainty, then we find that the gap is actually scaling with lambda to the alpha. So it's actually growing quite a bit. And so we say there's actually a benefit to doing surge staffing in this particular scenario. And intuitively, this makes sense. You probably didn't need the theorem to tell you that if there's a lot of demand uncertainty, the value of resolving that uncertainty is going to be substantial, right? But now we're able to actually quantify what does it mean to have enough uncertainty. So I would say that's the benefit of the theorem, but kind of the intuition should have been there hopefully earlier. All right, so what I'm going to do from now on is I'm going to assume that we are in this dominant uncertainty scenario, because otherwise I'm not going to do surge staffing. And then I could just stop, I guess, if that's the case. All right, so let's first just to give you a little bit of data, just like, is it even realistic? Are hospitals in this particular regime? And I don't want to go through all the steps on how we estimated the alpha, but using the data from the Columbia Medical Center, we find that actually the resulting alpha is 0.77. So it seems that that adult ED is in that dominant uncertainty regime. Interestingly, we used some of the data from the CSTAT lab at the Technion because that's publicly available data. It's not as fine grained, like we don't have the EMR data. So we have arrival counts and we have, day of week and time of day, and we were able to put in the holidays and weather patterns and Google search, but we didn't have, how many patients with depression, how many patients with heart attacks, unfortunately. But with that, we also, I think, did I put it here? No. I think it was like 0.69 or 0.68 alpha as well. Interestingly, we also had some data on a psych, so a behavioral health emergency department, and that actually had a low alpha. And so it was less than 1/2 in that particular setting. And I guess there's, unlike, environmental factors that are creating a lot of the uncertainty, like the flu, like, I don't know, pollution events that can create surges. For behavioral health, it seems that there was a more steady arrival rate over time. So that's all to say, in most, I think, general EDs, it seems that there is quite a bit of uncertainty, and there may be settings where there is less. All right, so let's look at this staffing problem again. We're trying to find how many staff at the base stage, at the surge stage, to minimize the base staffing costs plus surge staffing costs plus queuing costs. All right, and we have these two sources of randomness again. The parameter uncertainty and the arrival rate, that's on order lambda to the alpha, and the system stochasticity due to the queue process. Here, that's order square root lambda. And so what we were able to find in that prior theorem was that if alpha is greater than 1/2, this gap scales according to lambda to the alpha. All right, so we know there's savings. We don't know what to do yet. Hopefully we'll get there. So I'm going to first start with and propose a 2-stage staffing rule. So in prior work done by others and my colleague Asaf, looked at when you didn't have that second stage opportunity. So you could only do base staffing. And so they found an optimal staffing decision, an asymptotically optimal staffing decision. That essentially this is a news vendor model. So because you have high parameter uncertainty and it's dominating the system stochasticity, essentially you can ignore the system stochasticity. It's really all of the uncertainty that you're worried about is in that parameter of what the arrival rate is. And so they take an approach that essentially looks at a fluid model. So replaces all of the stochasticity with deterministic arrival counts and fluid, and you end up basically hedging between what is that actual arrival rate going to be, having too many staff paying the extra cost, or having too little to not be able to actually meet the total demand. And so that's the optimal policy at the base stage. Now, if you had a second opportunity, we thought, well, why don't we try to kind of mimic that? So we're going to start at the first stage, do a news vendor. When we see what the arrival rate is going to be, we can now match, maybe you got it wrong. We actually have an opportunity to fix that. So if we turned out to staff too little, I'm going to add more. Now I can't tell my FTEs, I'm not going to pay you. So there's still the cost of having too much staff, but you actually have this opportunity to make sure that you don't have too little staff. And so we refer to this as that's two-stage news vendor rule, because you're still solving a news vendor, but at that second stage, you can basically close the gap completely. And so we find in doing this, this policy that we propose relative to the optimal two-stage is big O of square root lambda. So it scales with square root lambda, but it's on the order of the system stochasticity instead of at the order of the parameter uncertainty, which is larger. So we seem to have gotten some benefits there. And if you compare these two policies, we're still seeing this gap though of order lambda to the alpha. So we were like, well, you know, that's kind of the order of the gap that you're going to get between the first and second stage, but can we actually make this a little bit better? Can we do anything? And so we realized that there was a missed opportunity to just meeting the arrival rate exactly at that second stage. We actually have more opportunity. So we have all of the parameter uncertainty is resolved, but we know a lot about the queue process. And so we can also optimize over that queue process now that we know that there's only system stochasticity. We can optimize over that system stochasticity. So we consider a refinement, and we refer to this as the two-stage QED rule, because we're using that QED analysis that allows us to see what is happening in the queue length process and approximate it using the QED approximations. So it looks in structure very similar to the original two-stage news vendor rule that I mentioned. So you have a parameter at the first stage, that's your news vendor hedging. And then at the second stage, you first meet the demand from that from the news vendor, that order lambda demand. And then we're going to refine it on the order of square root. We're going to do the optimal square root staffing rule around that optimal lambda amount. So we may add a order square root lambda staff above, or we actually may take order square root lambda staff below. And so when we do this, we actually find that now, essentially, as lambda goes to infinity, the gap is eliminated. And so this is an asymptotically optimal staffing policy where it's growing little o of square root lambda, whereas our prior one was growing as big O square root lambda. So you're still stuck with that square root lambda of gap. And we've now eliminated it by capturing the fact that we can optimize over that system stochasticity. So I guess what I would say that the main takeaway from the theoretical analysis is twofold. One is, if your parameter uncertainty is sufficiently large, then there's benefits to surge staffing. What's sufficiently large? It is larger than the system stochasticity, order of the system stochasticity. If you do that, then a policy that'll allow you to get an asymptotically optimal staffing is to first solve a news vendor problem to hedge against the parameter uncertainty. That's at the base stage. And then at the surge stage, you hedge against the system stochasticity in that queue process. All of this analysis that I've told you so far assumed that we knew the predictions exactly. So I know exactly what the arrival rate is going to be. But we can actually consider the case where we have prediction error. And so the way that we model this, I'm not going to go into all the details, but you could essentially split it into twofold. You have part of the arrival rate that you can predict and part that you can't predict. And so perhaps not surprisingly, as the amount of uncertainty in the unpredictable part increases, as you shift more to there, then our policy is going to start to degrade past the optimal single stage. Although we do have a policy that allow us to make sure that we essentially, you utilize the prediction until it starts to hurt you, and then you ignore it and you move to the single news vendor model. All right, so we wanted to think about how this could be used to guide real staffing decisions. So we created a high fidelity simulation, various features that we relaxed from the kind of stylized model that I have been talking about for the last 50 minutes. Time varying arrival rates on the hourly level, log normal lengths of stay. You can only add nurse servers quantized because you have these nurse to patient ratios. And then, back to Jonathan's question earlier, this transient shift effect becomes a challenge, and it becomes a big issue when you're shifting from night versus day, because at the daytime, your square root lambda fluctuations that you can't avoid because of system stochasticity, when the demand rate drops at night, those actually become order lambda errors. And so if you don't account for the fact that you have this spillover across the shifts, you end up in a situation where you're severely understaffed. You actually have to make sure you add additional staff to account for anyone that's left over from the morning shift. And so we kind of do this heuristically using some intuition and the queuing factors. But what we find using a simulation calibrated to these numbers we found in the literature, in the purple is our policy, and we're using right now the actual prediction policy, like the accuracy of the predictions we see in practice. We're not assuming perfect prediction anymore, versus the single stage optimal, the news vendor model. So this is saying that if you don't surge, but you do the optimal thing. I think this is an upper bound on what hospitals are doing if they don't surge, because hospitals are probably not optimizing over the parameter uncertainty. They may be here like close to it because they kind of over time has managed to figure out, but I think, this is a reasonable, benchmark to be comparing against. And so if you look at different measures of quality of care, average waiting time versus percentage of patients left without being seen, you can see that there's, it's Pareto dominating to take our approach. Just to kind of put some more concrete numbers on it, because where are you going to actually operate on those trade-off curves? We considered some reasonable metrics that a hospital might want to try to target, and then say, what is the difference in the staffing costs to actually meet those target performance measures? And so these are different ones, but relative to that single stage news vendor solution, if we want to target an average waiting time of less than 30 minutes, we get $2.9 million. Percentage of patients who abandon the system, less than 2%, it's 1.79. If less than 20% of the patients are going to wait more than an hour, 2.5 million. So it kind of ranges between like $1.5 to $3 million over the course of the year, which, with staffing costs being a really high portion of costs at hospitals, and with many hospitals going bankrupt or having negative operating margins, these can be quite substantial. So we showed these results to a hospital in New Jersey, and so they were really interested in actually conducting a pilot study. So this is what we're working on right now. We have built a toolbox to both do the prediction and then send the staffing recommendations to them at every shift. And actually at their hospital, they have staggered shift, as many hospitals do. And so what we're doing is actually trying to determine how much staff to have at the beginning of each of those shifts based on information as it's being updated. So we've already calibrated the model. We had our meeting last week with the department leadership. Starting next week, the plan is to have our tool running real time. They want the charge nurse that does all the staffing, wants to kind of see the prediction in action before. She wants to make sure the prediction is doing the right thing before she trusts the decision that the prediction is guiding us through, which is fair. And then after a month of that, we're going to do a month of status quo. So we're going to take away the prediction and just let them staff as they wish. But while we do that, they're actually making the base staffing decisions for our on period. Because our on period, our recommendations are not just how much you surge, but we're actually appropriately adjusting how much you have at the base stage because you have this additional opportunity to surge, right? And so you actually sometimes end up staffing lower because you know you later, if you were too low, you can surge up. And then so hopefully by the end of the summer, we'll have some data on how it actually worked. We're currently iterating with them of how we're going to send the recommendations. And so our plan is to send this report, which is giving the forecasts for the next. So these times don't correspond to the shifts. The beginning of the time corresponds when the shift begins. So those are really like opportunities to change the amount of staffing. And then when the confidence intervals of those predictions. And so you can see there's actually quite a bit of range in the prediction. But again, to get more understanding of like how accurate these are going to be. And then what we'll do is for the next day, we'll say, this is how many people that you should have staffed at each of the shifts. And then they have an option to say, why didn't you follow it if you didn't? We're hoping they will follow it, but from my experience, optimistically, if they follow it like half the time, I'm going to consider that a win. So I guess I'm pretty much out of time, so I'll wrap up here, and hopefully I'll see some of you and I can tell you about the results of this when we actually get it done. Is really trying to think about these predictions and that value of having the real-time information. We saw that actually there was economically meaningful improvements that can be achieved with this approach, despite the fact that the improvements in the prediction were relatively small. And so certainly if you can improve the prediction, we can get even larger benefits. So thank you so much for your time and attention today, and happy to answer any questions.
A quick question. How far in advance are you giving the information to the hospital?
So for the base staffing decisions, because they make the decision 4 weeks in advance ahead of the shift, we have to give it to them 4 weeks in advance. For the actual surge decision, we are giving those predictions and the recommended staffing. Basically, they wanted it at the day level. So we originally created the model, so like 2 hours before every shift, we would do it, and they thought that might be difficult for them to find people to surge, and so they said, like, let's do it at the morning. So at 5 a.m., tell me how many I'm going to need for the rest of the day, and that will be enough. We've also actually played with some interesting models. They're open to it, but we wanted to try it with our current payment scheme of actually having like a nominal amount to have people agree to an on-call shift. So instead of, it's like, let me pay you 10% to say I'm on call for the shift if surge is necessary. If we don't surge, I just get to pocket that 10% and I have a free day. If we do surge, I'm required to come in and I get paid 1.5. You can also use this approach and you get similar types of savings. And so that's an option that maybe in the future, if we have trouble getting people to surge, we'll have to try out as well.
So thank you very much. I think we can have time for one very quick question because I want to be cognizant of the small group meeting time. So any last questions? All right. Okay. Feel free to cut the recording. And I'd like to also mention to all the PhD